There we go. So, welcome. I know we've got a few more folks that are joining, and thanks to each of you who are joining for today's session of MI and medicine and healthcare. Thanks so much for being with us today. Great to see, as we mentioned, familiar faces and names and such great participation. Amanda, you are a hit. You're a draw here today. I'm Jody Herford, registered nurse and member of Mint and a board certified health coach. And I have the privilege of working alongside Dr. Stephen Cole, who's really the visionary behind MI Med and has really kicked this off. And we're really looking to continue to grow the opportunities and how people are using motivational interviewing in medicine and healthcare. Another member of our stellar team is Heather Austin, Dr. Heather Austin down at the University of Alabama in Birmingham. And Heather does so much for us behind the scenes to ensure really the smooth operations. So thanks to both of you. Before we jump into today's agenda, I would like to take a moment and recognize that it is Veterans Day here in the United States, and to take a brief moment to honor the dedication and bravery of our service members who risk their lives to protect our country, and to offer a heartfelt thank you for their and their families' dedication, their enormous sacrifices, and for their many contributions to our country. So thank you to our vets, thank you to our members of the armed services, and thank you to their families as well. So quick note on MI Med, or MI in medicine and healthcare, because I know we've got a number of new faces and possibly you're new to this group. We are a small informal group. And Steve, I'm going to ask you to add any 2 cents that you have to this as well. But we're folks who are interested in using MI in healthcare, or you plan to use MI in medicine and healthcare. And we typically come together as a group a couple of months to look at lessons learned, solutions sought, stories of how MI is being integrated into the delivery of healthcare and into our interactions with our patients. So I will put the sign up link for the mailing list so that you can be a part of that. If you haven't already signed up, please do. I'll put the link in the chat here in just a moment. And as well, we really invite and welcome your ideas and suggestions for what would be most helpful to you as we move forward. We tend to come together every couple of months. As I mentioned at the end of the session today, I'll let you know about upcoming sessions. But would definitely encourage you to send your suggestions. I'll also put my email in the chat. So if you have ideas and suggestions on topics or presenters, please feel free to share those with us, because we're looking to make this as helpful to all as we can. Steve, what did I miss in that just brief intro?
That was lovely and efficient. Thank you so much. I'll just be extremely brief because we have so much we want to talk about. But thank you for a kind introduction, Jody, introducing me as the visionary. I think what that means is that when I joined Mint, the Motivational Interviewing Network of Trainers, in which there's several of us here, but I see I don't know, it seems most of us are not, which is exactly what I was hoping for in the original vision. So 10, 12 years ago when I joined, I started offering the opportunity for people in the annual Mint Forum to get together and talk about MI in medicine. I'm a physician and interested in communication as well as other things. And have been struggling with, as many perhaps of you and others have been, finding good solutions to bringing MI into the healthcare world. From a big step that Heather first, and now Jody particularly, and now Amanda, that we've been making. MI Med from the very beginning has had the vision that we want to be well beyond the borders of Mint land, so to speak, because there are so many people in healthcare who are interested, have noticed the evidence behind MI, who are beginning to try to integrate it or already have done quite a lot. So that's what MI-Med is about. And so that's why we are making this pitch for, and Jody's been so creative in helping us reach out, and Amanda now. Please sign up to the MI-Med mailing list if this work interests you. There's no obligations. You'll be getting notified and no cost. You'll simply be getting notified of the work that we're doing. And this is one piece, and there are others. And I won't take away any more time from Amanda's topic other than saying welcome. Thank you to Jody and Heather and Amanda and all of you who are here.
Thanks. Thanks, Steve. I'm going to do a quick introduction to Amanda, but I think it would be really helpful for folks to, put into the chat both where you're zooming in from, and as well what your background is, or are you a coach? Are you a genetic counselor? What is your line of work, and or how you're using or hope to use MI in your conversations? That might give Amanda a little bit of an idea as to who all of our 47 participants are on the call today. So today's title, or the title of today's session, is Empowering Conversations, the Role of MI in Oncology Genetic Counseling. And our special guest speaker today is Amanda Nacimento. And Amanda is a licensed certified genetic counselor and national board certified health and wellness coach. With over 25 years of laboratory and clinical genetics experience, Amanda appreciates the potential impact of inherited risk factors on chronic illness. In 2020, Amanda broadened her skill set to include health coach training, where she was exposed to motivational interviewing. She uses MI to help patients address their ambivalence about inherited cancer testing. For those who test positive for a high-risk gene mutation and wish to address health-related behavior change, MI has been a powerful tool to support their autonomy in making lifestyle modifications. Amanda also uses MI in her private health coach practice, CoachAmandaN.com. And when not serving her patients and clients, Amanda can be found conquering one peak or another in the White Mountains of New Hampshire, or curled up with a mystery novel and a hot cup of coffee. And I just love to say that Amanda is also one of our prize students and graduates from the ADAPT Health Coach Training Program. So it's really great and truly a privilege, Amanda, to see how you're using and continue to develop those skills. So without further delay, I'm going to turn it on over to you. Thank you for being here.
First, thank you for that introduction. I'm going to start screen sharing. And then please let me know if that doesn't seem to work. I'm trying to get the slideshow going. Okay, is everyone, all right, now I'm seeing nothing. That is not going to work. Let's see. Oh, sorry. Okay, here we go. So thank you again, Jody. It's been just such a journey. This whole motivational interviewing and oncology, genetics, and everything. And I'm thrilled that there's so many genetic counselors on the call today, actually. So Jody already introduced me, so I'm going to skip that. The objectives that I have for today that I hope will come to fruition is really to explore how MI can be used in oncology, genetic counseling, and really healthcare more broadly, to support patient autonomy, to introduce the idea of behavior change. My context is cellular health and DNA health, but certainly behavior change can support all sorts of health in general. And I also hope to show how MI and oncology genetics can really be used to plant seeds for personal growth of our patients. Also, I would love MI to be a little more common in healthcare, particularly genetic counseling. And I really think genetic counselors, given our skill set, which I will talk about in a few minutes, can really contribute amazingly to increasing the reach of MI in healthcare. And health coaches are so needed and necessary in healthcare, even if, capital H healthcare doesn't know it yet. But that is part of probably a discussion for a different day of how I'm really trying to get health coaching into mainstream healthcare. My BS is in biology, my master's is in genetic counseling. And as Jody mentioned, I've been a genetic counselor for more than 25 years, and I've worked in a variety of specialties. I've been in oncology genetics almost 5 years. So next few weeks, actually, it'll be 5 years. And I'm also a functionally trained health coach. My interest really is in chronic illness prevention and mitigation. Obviously, cancer is an interest of mine. And, I would really love to bring this modality to lower income populations where I really think it's necessary and underutilized. So for those of us on the call who aren't super familiar with MI, this is just one little sentence to try to encapsulate it, which obviously I can't really do in one sentence, but it's a particular way of talking to people about change and growth to strengthen their own motivation and commitment. So genetic counseling is a little different, but if you imagine a Venn diagram, MI sort of one circle, and the communication style we use in genetic counseling, there's a really big overlap in that Venn diagram, which I hope to illustrate today. There's a particular way of approaching the MI in use with people called the spirit of MI, and there's a few qualities, I guess: partnership, acceptance, compassion, and empowerment. And then there's 4 tasks in MI, including engaging, focusing, evoking, and planning. And again, such a nutshell for a modality that is more than an entire book. So, grain of salt here. Genetic counseling, I'm guessing a lot of people on the call don't actually know what genetic counseling is or are very familiar. So again, to encapsulate something very big into something very small and concise, genetic counseling is a service aimed at providing information and support to people, to families who either have genetic disorders or are at risk for genetic disorders. Genetic counselors have advanced training in medical genetics. We also have training in counseling. So what we generally do is guide and support people and help to interpret genetic test results, but not just the science of the result, but how that really applies to families and people and how they can use that information to, manage, basically. So it isn't just the science, it's the science and the people together. Most genetic counselors have a master's degree. Increasingly, some are getting PhDs. So it's becoming more common. So basically, genetic counselors are science geeks who really like to talk to people and are really good at talking to people. So we're really the bridge between, the clinical research and the clinic. Lots of areas of specialty where you might find a genetic counselor. This list is not complete, but just to give you a little flavor of where genetic counselors hang out in healthcare. And some don't actually even see patients because the skill set that makes genetic counselors somewhat unique also translates to a lot of different areas. So not every genetic counselor is in the clinic. Briefly, an excerpt from the National Society of Genetic Counselors Code of Ethics. Genetic counselors work to enable clients to make informed decisions free of coercion. So autonomy is really important. So free of coercion. And again, it's information, it's education, and it's helping people to understand alternatives and anticipated consequences of what they decide. And that's where a lot of the counseling part comes in, because consequences sometimes depend on the context of that family. The primary focus of a genetic counseling session is not change and growth to strengthen motivation and commitment. And I know that was a big part of what I said MI is. So genetic counseling and what we aim to do in a session is not exactly consistent with what MI is aiming to do. But again, if you imagine that Venn diagram, there's a big area of overlap. A lot of what genetic counseling is about are open questions, affirmations, reflections, and summaries, which I know will sound familiar to a lot of people on this call. So again, the Venn diagram overlap. Just a little bit about oncology genetics. So we're not really supposed to call them mutations anymore, but I actually do in the clinic because mutation is easier to say and understand than pathogenic variant. So we'll just get that out of the way. I'm not supposed to say mutation. A small percentage of cancers are actually due to inherited mutations in high-risk cancer genes. So you may have heard of BRCA1, BRCA2. These are, high-risk cancer-related genes. Now, genetic test results, so being tested for mutations in some of these cancer-related genes can do more than what people might think. So genetic test results can inform cancer treatment in certain cancers at certain times and certain test results. So it can actually help a surgeon or an oncologist manage cancer treatment. Genetic test results can also inform recommendations for cancer screening. So for example, if somebody tests positive for a high risk, colon cancer gene, then their recommendation for colon screening, like colonoscopy, would tend to be much more frequent than once every 10 years, which at least in the US is the screening recommendation for a standard risk person, so somebody who's not high risk. Genetic testing is a little different from, blood glucose testing or cholesterol testing in that, there are implications for blood relatives, and lots of times people are worried about their children. So genetic test results can, testing one person doesn't necessarily give results for another person, but it can at least put people in higher risk pools. So it's just more than again just getting your blood glucose tested. There are implications beyond the individual. And unfortunately, at least in the US, genetic testing can sometimes affect certain types of insurance coverage. So I say all this and list all this to illustrate what genetic counselors bring to the healthcare table, because it takes kind of a long time to talk to a family or a person about all the different implications of genetic testing. And so, in physicians and, other healthcare providers don't necessarily have the time to dig into the pros and cons and the implications of having a genetic test. If someone has cancer, my referrals will typically come from the GI doc, the surgeon, a radiologist, or an oncologist. If someone doesn't have cancer, but they're high risk due to their family history, those patients often, at least in my clinic, come from their primary care or GYN. So the situation is really the context of the clinical situation dependent. I see two main types of consultations: patients with cancer and patients without cancer. But there's also certain red flags that we look for. So for example, certain types of cancers at young age, and young is sort of loosely defined as 50 or younger, clusters of cancer within the family, also running through the generations, is something we look for. If there's a presentation that's somewhat unusual, like breast cancer in a male, that's a red flag that there may be an inherited form of cancer in the family. And then, other situations, like, for example, metastatic prostate cancer. So in terms of pre-test genetic counseling, so again, before someone's had any genetic testing, they come to sit with me and lots of other people, around the country, to talk about that. And so those consultations, at least in my clinic, I'm afforded about an hour, which I understand is somewhat luxurious, and I so do appreciate that amount of time. So what I have learned the hard way is to ask first, what is your understanding of why we're meeting today? And that comes from getting halfway, 2/3 of the way through a pre-test genetic consult with a young woman who did not have cancer. And what I found out almost all the way through the session was she was wondering when I was going to tell her she had cancer and tell her what type. Patients or clients are our best teachers. And so my every session starts with, what is your understanding of why we're meeting? Because I'd like the time that we meet to be fruitful. And I'm sure she got nothing out of what we talked about if she was just waiting for me to tell her when, what type of cancer she had. So I learned my lesson. I'm the lifelong learner, always learning. So what's your understanding of why we're meeting? In genetic counseling, we call this contracting, but it's basically co-creating a session with a client or a patient. And then comes the what could be in the coaching world, we would call it sort of an inquisition, right? It's medical and family history, very closed-ended questions. So what I try to do, again, to incorporate MI into this a little bit, is sprinkle that with reflections. So if someone is telling me about their family history of cancer, maybe, my mother was diagnosed with cancer at age 43. And then, if I do a quick little mental math and realize the patient was, I don't know, 17 years old, I can say, well, you were very young. That must have been really difficult. Or, you had to grow up quickly, or you were really dealing with heavy things that other 17-year-olds didn't need to deal with. Just a little bit, a little breaking up the questions with some reflection, some affirmations. There's a lot of education in a pre-test genetic counseling session, and I really try to frame that as ask, offer, ask. So the difference between, say, coaching ask, offer, ask, where you might ask for permission to share information. I don't ask permission to share information because I feel like they've come to me. I have implicit permission to share information. But that said, what do you know about, for example, genetics of cancer, pros and cons of genetic testing? So trying to really elicit what they know before I launch into, what is genetics and what are genes and, the whole thing. And then really following up, like, did that make sense? What do you make of that? What do you think about that? What questions do you have? I love metaphor, and metaphor works great genetic counseling because, particularly baking, although I do use Legos sometimes, but basically genes are recipes for proteins that do something, like, for example, suppress the growth of tumors. So if you imagine a genetic mutation, like a misprint in a recipe, where maybe the recipe leaves out something like whatever, baking powder, you can kind of really make that visual for someone, because everybody knows, you get a muffin that didn't rise, or somebody forgot the sugar, or there's no flour, or whatever, that makes, I think anyway, makes the analogy with genetics more clear. So you have this gene, BRCA's not a bad gene, BRCA's a really super important gene, but if it has a mutation, it's not going to be made, properly, or enough of it, or whatever. And then it's not going to fight cancer as effectively. So again, just bringing in some of the tools. That's not exactly MI, but just really trying to help use things like metaphor to get the point across. Genetic counseling is a lot of evocation, evoking their feelings, their desires. What do you want from this genetic risk information? What do you value about knowing your risk? Ambivalence, all of us have to, well, personally, and I guess in our professions, deal with ambivalence. So, and there's a lot of that around genetic testing. So commonly I'm reflecting something like, you're nervous about getting positive results and you would like information. What do you need to bring clarity? What do you need? So just really trying to not make assumptions, to really bring them into the conversation. And then there's planning. Planning is either, do we draw your blood before you leave today? Have you decided you want nothing to do with genetic testing? Or, the next step might be thinking about it or looking into life insurance or, calling Aunt Myrna, whatever. Did she have genetic testing? What were her results? So sometimes planning is, kind of a loose thing, but it's a next step. It's what are we doing next? And I always remind people, your genes are going to be with you forever. And here's my card with my phone number. So, nothing necessarily needs to be done that day. But say we do test somebody and they test positive for some mutation in a high risk gene. And they come back, typically, that's the way we do it, is I call them, I let them know they've tested positive, and I actually call negatives and inconclusives as well, just because, I don't know, I like to close the loop with my patients. So anyway, so say they test positive, they come back to find out what's going on. Those consults are usually a little bit shorter, but I still get quite a bit of time. So in the scenario where someone has cancer and they test positive for, say, a BRCA mutation, we sit down and the first question I ask is, how are you feeling at this moment? Because sometimes people with cancer don't feel very well. I just want to get a sense of how they're feeling, but sometimes the answer I get doesn't have anything to do with physically how they're feeling. Sometimes I get I'm scared or I'm confused or I have no idea. So I just really like to kind of evoke a little first, like what's going on, just to check in first. And then always, what do you make of your test results? Some people have looked at the results. I send them through the electronic health record. Some people looked at them. They've been on Google all weekend. Some people haven't looked at them. So what do you make of this? What would be most helpful? Because sometimes, especially again, when people have cancer, they don't really want a lot of information necessarily. They just kind of want okay, give me the basics because I've got a lot on my plate already. So I always like to ask them what would be most helpful during our time together, and then ask, offer, ask again, but that very much depends on patient preference. Preference. Some people are very tired, very nauseous. Most are overwhelmed. I mean, they have cancer and now they have bad news about carrying a gene that now they're worried about they're going to pass down. Many need a little empathy and some tissues, sometimes they just need a place to cry. I'm not a therapist. I'm not the social worker, so I don't spend the whole time doing that. But if they need to cry a little first, like better out than in, and then we can get down to what we need to for the session. And then I always try to bear in mind chemo brain is real. For those of you who don't know what chemo brain is, chemotherapy is very toxic, and that's part of why it works to kill cancer cells. But it also affects the mitochondrial health of all the cells. And so sometimes that leads to brain fog. So chemo brain is physiological, it's real, and sometimes people just can't really focus very well. So I just really try to gauge what's going on with the client. And then always when someone tests positive, I just send a one-page letter so that they don't have to do a lot of explaining to their at-risk blood relatives. They can just hand them this paper that person can then take to their doctor and maybe, either come see me or another genetic counselor, especially if they're not in Massachusetts. So just really trying to connect with the patient and maybe what they need and just try to make this part of their journey a little bit easier. Now, post-test genetic counseling in someone without cancer who tests positive is really where I see MI shining most brightly in oncology genetic counseling. And these are by far the most fun sessions that I have. Again, what do you make of your test results? Because I just want to know where people's brains are and what would be most helpful. commonly I'm reflecting just based on what they say to those questions. A lot of times my reflections are, you want to understand your test results and figure out a plan. What else? What would you add to that? You're worried about your children, and that's so common. And any of the oncology genetic counselors on this call right now, I'm sure would agree. It's so often top of mind is kids. If someone doesn't have kids, they're thinking about their siblings, their nieces, their nephews, their cousins. This is such a family affair. So you're worried about your children. You obviously care about them a lot. So throwing in an affirmation, and we'll be sure to talk about them. Don't worry, we'll definitely address that. So just trying to again co-create, affirm, reflect, do what I can to use MI. As always, ask, offer, ask depends. Most often in a post-test genetics session, we review their test results, their cancer risks and recommendations that follow those test results. And then asking again, how is this sitting with you? What questions do you have? What's going on in your mind right now? And I try to emphasize nothing needs to be decided that day. You are the same person you were 3 or 4 weeks ago. We just know more now. So take a deep breath. I know this is stressful, but nothing has to be decided today. And so I just try to bring the stress down a little. And because I'm a health coach, what do you know about reducing your risks of cancer? And then here's where the should buts come in. Should but, should but, should but. I know I should quit smoking, but it's so hard. No, I should exercise, but I'm so tired. So it's that decisional balance or ambivalence just hits so hard. People know they're not supposed to smoke. Of course, we all know that, right? But doing it is really hard. So would you like some information on ways to decrease your cancer risk? And I specifically ask this as a closed question because they didn't come to me for health coaching. They came to get some information. So I want them to easily be able to say no. I don't know if anybody's ever said no to that question though, because yeah, no, I'm good. I don't really want to know how to stop cancer or at least decrease my chance. Most people say yes. So then very briefly, I talk about mitochondrial function, DNA repair. A lot of these cancer-associated genes or cancer predisposition genes have to do with DNA repair. Not all of them, but so just a little bit of how the mitochondria and the DNA, which are in different parts of the cell, how they interact. There's a bidirectional relationship between the health of these functions in the cell and just general cell health. But I put that's sort of the context, but the spin on it is lifestyle. So again, the big ones, right? Nourishment, exercise, stress management, sleep, smoking, alcohol. And I don't get into every detail about everything, but just really trying to connect lifestyle, not so much with, well, we exercise so we can lose weight. Well, maybe, but in this case, we exercise so that our cells are healthier and they work a little bit better and we're better able to decrease the chance of cancer or better able to be resilient. And then pulling in values, what's important to you about avoiding cancer? And commonly, and again, it comes to family for a lot of people. I want to be there for my children, my grandchildren. I watched my mother suffer. I don't want that for my children or my nieces or my nephews. I don't want my siblings to have to take care of me. Plus, nobody wants cancer because, nobody wants cancer, right? So then, if I have time and they seem amenable, what does smoking or Netflix binging, what does that do for you? Because even though we have behaviors that we know intellectually aren't serving us, they do serve us in some way. They serve a purpose, right? Stress relief. Who's scrolling on their phone at 11 p.m. for anything other than just time for themselves or stress relief. Like that's kind of to tune out from the day. So I try to take those answers and oh, so you're really trying to take care of yourself. So watching too many shows on Netflix at 10 or 11 at night is because you want time to decompress. So that is serving a purpose. What might serve you a little bit better? And commonly, I don't know, because people are, I don't know, they certainly didn't come to that appointment expecting to be asked about their lifestyle. So a lot of times people haven't given it much thought. Well, I don't know, if I'm not scrolling Netflix or I'm not smoking, what can I do that will give me the same result but serve me better? And a lot of times people don't know. Sometimes I'll get I could call my friend. She's also trying to cut down on wine or beer, whatever the thing is. So sometimes you can really pull in, other people's resources in a short period of time. And then a lot of this stuff comes down to fear. What's getting in your way of scheduling the mammogram, the endoscopy, the colonoscopy, whatever it is. Sometimes it's because it's uncomfortable or it's embarrassing. Sometimes it's taking off work. And actually, for the patient population I have, taking off work can often be distressing because, in my population, social drivers of health are ever present. So, for some people, taking off work means they don't get paid. And that's really that's a real decision that they need to make. So there's lots of reasons why people don't do things like colonoscopies, but a lot of it comes down to fear, not all of it. And for those of you on the call who've never had a mammogram, nobody looks this happy. Mammograms are uncomfortable. They are a little embarrassing. You do have to take off work. Yeah, I would rather not do that too. I don't think I'm going to really need to narrate this one. Some of you might find it a little funny. Some of you maybe not so much. But, healthcare isn't always a picnic. Let's just leave it at that. But what I do try to do as I wrap up, and this is always a good way to kind of wrap up the genetic counseling session, is to say, as we wrap up, what is one thing you can do to take care of yourself today? Commonly, I don't know, or dinner is always the stress factor at the end of the day, or very occasionally I could take a walk outside. I like fresh air, so just trying to plant the seed, one thing at a time. What can you do today? So some of the challenges to using MI in the oncology clinic, as any clinician will tell you, there's time limits. Again, I have a long time and it's still challenging for me, ways to get in the open questions, the affirmations, the reflections, the summaries, the, really empathic listening and everything. It's not easy. We have a time limit. With genetic counseling, there's a lot of education involved. So getting enough education to facilitate informed consent, but still supporting autonomy and empowerment of the patient. And so there's a balance to be had. And then planting those seeds for behavior change, knowing that I'm really probably only going to see the patient once or twice. So I'm not going to have time to help them, weed the little, to watch the seed germinate and weed the garden and tend the flower or whatever metaphor you want to use. I probably won't see them again unless they have cancer. And then it's just like a hug and a hello in the waiting room. So, this is really my challenge is how do I plant the seeds knowing I won't be able to help them tend that garden? And again, I have a few ideas about that, but that's a topic for a different day, I think. MI is valuable. It's certainly underutilized. Genetic counselors have a lot of skills. Again, that Venn diagram, there's a ton of overlap. And I really think genetic counselors could add a lot to the MI Med group or to the motivational interviewing network of trainers. I just see this as such a symbiotic, the fields are very, a lot of overlap in the skill set. And again, boy, are health coaches needed in healthcare. I mean, even the best intentioned clinician who really wants health-related change for their patients just doesn't have the time in a focused appointment to really, well, tend to that seed, help it germinate, weed the garden, really help people to blossom, if I can use that metaphor to death, I guess. So as imperfectly, as I may use MI, and I'm always learning, my goal for every consult is really to create an atmosphere where, regardless of what people are doing, what behaviors they're using, what behaviors they won't quit, I just want them to have a place where they can be vulnerable and honest and just really feel respected. As individuals and people who are able to have autonomy and be empowered and take some ownership of their health. And again, really, regardless of where they were or where they are, like just to have a place where they can take a breath. And I really wish I could say this was a picture of my office, but it's not. I just wish it were. So that's just my.
Well, I missed three.
And this is my contact. I mean, genetic counseling I'm very limited to Massachusetts. We do see people in person and virtually, but they have to be in Massachusetts. Health coaching is not encumbered by licensure, so I am able to see people across state lines. So if there is anybody who thinks my services could be valuable to a patient or a client, I'm more than happy to be a resource. So I welcome any questions. Thank you. I'm going to stop sharing.
Amanda, thank you. Wow. Your heart and passion and compassion, both for the privilege we have to coach and to integrate MI, comes through, and so much to take from your presentation. I know there are a lot of questions out there, so please, if you're able to raise a hand, we can take them in order. I know Betsy has a question, and if not, as soon as Betsy's through, please feel free. But I just want to highlight a couple of the things that I heard from you. One being, our patients are our best teachers, right? I mean, that for me has really been such a tenet of coaching and MI practice, that what works, our patients will let us know, and what doesn't work, our patients will let us know. So Betsy, I'm going to turn it on over to you, and then folks, get your questions ready.
Thank you, Amanda. That was amazing. I learned a lot about genetic counseling, but also can really see the value of both coaching and MI in all of medicine. It was really beautiful. Two quick questions. One, why are we not supposed to say mutation?
Yeah. I think it's just more, I don't know. First of all, I think it's a little, kind of sounds abnormal. It sounds, I don't know, like, I guess we don't want to insult the genes. We'll just say that. But also, I think, we all are a little bit different in our genetics. So, pathogenic variant. So we all have variants, whether they're disease causing or not. And then also my guess is too, and I've not heard this as I'm just thinking about it, like not all mutations lead to disease. So in some people, maybe they are just variations that don't come to fruition. So I don't know if any other genetic counselors have something better to say or more coherent, please put it in the chat.
Yeah, but people understand what you're saying when you say pathogenic variation.
Genetic counselors do, but
yeah, right.
So that's why I say mutation.
Oh, yeah, got it. So the other question is just what changed in your work as a genetic counselor when you learned and brought in MI?
I've been asked this question before, and I still haven't formulated exactly my answer because I feel like it's such an evolution. There was no switch. But I think probably for me the biggest thing is just finding out first what somebody wants and needs from the session, and then also the ask, offer, ask. So swinging back with them. How does this sit with you? What do you need? What do you value? Just making sure that my session isn't just information from like download from here to them, but really the interactive and then checking in with them. And probably a lot of other genetic counselors do that. Maybe I just never really thought too much about that until I really had the MI training, and I was like, oh yeah, that's actually really important. So did that answer your question, Betsy?
Yeah, one little last thing is, have you noticed a shift in effectiveness or people's engagement with their own health since adding that?
I wish I could say, yeah, for sure, but I don't know what happens after I don't see them again. So I don't know if that seed ever germinates.
Yeah.
I get good, like, people will send me an email. That was really great. Thank you so much. That was so helpful. So I get good feedback, but I can't say whether their seeds germinate into anything other than just seeds hanging out in the ground.
Well, Amanda, your seed has definitely germinated and graduated and grown, and to just see the application, coming through, a health coach training program, and to see it actually in action and making a difference, because we've all been in healthcare conversations that haven't come from a place of compassion or come from a place of understanding. And hopefully we've all experienced the opposite of that in what you're demonstrating here. And that impact is powerful when we can see another and hear what they're saying, and it feels like they matter to us because they do. Yeah. There's a question in the chat from Michael, and it says, Amanda, kudos for sharing your gifts as a coaching with your clients. How do your clients generally respond when given a voice to share when they're usually talked to in healthcare?
I would say, Michael, that a lot of people, well, first of all, thank you. And I think I get a lot of, I don't know. That's a lot of the answers I get, because I think we're not used to necessarily walking into a healthcare setting and being asked or someone trying to evoke from us. So I think we're not accustomed to thinking that way. A lot of times people will ask me, what would you do? What do you recommend? I'll do whatever you recommend. And I, do the best I can to kind of dance around that and try to evoke from them. So I would say, Michael, maybe in general confusion or a little bit of being taken aback, but you can really talk people through that, well, why is this important? If you imagine getting your test results and they're positive, what does that look like? Or you imagine that they're negative, what does that look like? So I could kind of talk people through that a little bit, but initially I think people are kind of like, wait, what? I have a say in this? I don't, it's just a different way of communicating. And I would say that's pretty standard for genetic counseling. I don't think that's necessarily just me as a genetic counselor using MI. I think overall genetic counselors are pretty good at that. So.
What other questions? Oh, Steve, I see your hand up. Please jump in.
A quick thought, Amanda. Well, several things, more than just one quick thought. First, as others have said, that is just a wonderful, concise presentation. It's very compelling. I'm glad we're recording it. I found it so good for a few reasons, because you were able to bring in broad concepts and sprinkle it with so many examples from your own experience. And then from a teaching point of view, you're also telling us what you did and perhaps what you learned from MI, or through health coaching or both or everything. But this is a reflection and this is an affirmation and this is a question. So lovely, lovely, lovely. Lots of compassion came through, moving as a story and learning value. So kudos for all those things. I wanted to add a question or an observation, which is that I observed a little bit of a residue from MI learning, which I think is migrating, which is being apologetic for asking questions. And I really want to make a point there because I'll refer and put in the chat box a lovely article that I was already moving in this direction that reinforced my thinking. Peter Worley is a philosopher of education in England, of childhood education, and he wrote a very provocative article called something like "Closed Questions, Opened Thinking." So the point of the article, though, is to rehabilitate the value of closed questions. So I want to, and in fact, if the Mighty Coders and Terry Moyers and Denise have moved away from the thinking of the number one questions are, in a sense, bad or of much less value than reflections. And also the closed questions are a major sin. So that's changed. So this article is rehabilitating the closed question, is what the point of this was. And I want to add to that comment and suggest the way that not to be embarrassed or apologetic about the questioning that you've come to find very useful. And also just, and I've, in the work I'm doing, begun to think of a question that's conceptually open, is the way Peter Worley calls it, but we're calling these GCGs, which is a grammatically closed generative question. So that's moving the concept of ORs. You can still fit within it, because if we call it open questioning rather than open questions, we can retain the power of ORs. So instead of open questions, I'm wondering if we would consider, in the work that I'm doing, consider it open questioning. And let's just look at the very last question you used, which is a great one you had on your screen. It was something like, what is one thing you're going to do after you leave here? Now, that's an open question. And some in the concept of a GCG, a generatively closed question, if you turn, could there be in which that's somewhat autonomy limiting? It's somewhat, well, you have a right, you're a counselor, to be kind of suggestive or persuasive, or one might say, and I don't mean that you're ever controlling in the sense of your tone of voice, but what's one thing you're going to do? Wouldn't a closed question be more autonomy supportive? Is there anything you'd like to do after our discussion today that might work towards improving your health? So off the face of it, and that's a question that 10 years ago in the MI world was considered closed and bad, but now it's much more acceptable. But I'm suggesting that there's more autonomy support. In fact, in your last question, well, we've had this discussion today. We've covered lots of territories. Is there anything you might like to act on or do as actually preferentially and more autonomy supportive than some way of asking, what's one thing you're going to do?
Yeah.
Anyway, GCG is the idea. I'll put the article in the chat box from Peter Worley.
Sounds like a fascinating read, Steve. And I think you've also pointed out in your kind of questions and open questioning of open questions and closed questions. So much depends on spirit and relationship and tone of, how we're asking questions. So even an open question can come across as judgmental or pejorative. I think we come back down to that spirit. And I also think what you're saying is what Amanda said so early in her presentation of, we learn so much from our patients. and patients are going to respond differently to different ways of questions. So thank you for that. And Tammy, I see you have your hand raised. Please come on, or was that
I just took it down as long as you called on me.
Okay, perfect.
So thank
Great.
you for sharing that wonderful presentation, Amanda. I guess personally, one thing that's coming to mind is a family member that was diagnosed with a cancer, and then all of us were wondering, is it genetic or not? In this particular case, it was not, but it really made me deeply reflect on how that particular family member wasn't as healthy. It happened to be stomach cancer. So it's like, ooh, out of my family, they really don't have a good diet. So it made me like kind of be a little bit more aware of making sure myself and anyone I have influence in my family to, take better care of ourselves.
Great. Thank you, Tammy. Other hands? I mean, I heard your wish at the end, Amanda, and I stand with you in that wish of how do we spread motivational interviewing and really compassionate conversation. How can we help you and your fellow team members continue to spread the word and ideas and practice of motivational interviewing?
Well, that's a big question, Jody.
I know, and you got 3 minutes.
I don't know. I mean, I think, again, I appreciated so much genetic counselors being on this call, although I also feel like genetic counselors in general are compassionate, healthcare providers. I'm really working with one of the primary care physicians at my hospital, mostly to get health coaching into his practice. At least it's an uphill battle, but so I feel like the more I'm just poking at different doctors and advanced practice providers, the more I'm talking about it. I don't know, that's kind of what I know to do, is just kind of keep being a squeaky wheel. Obviously I would welcome any any good suggestions people have. So
Oh, well, we stand at the ready to help, certainly, in whatever way we would be able to assist any of you in bringing motivational interviewing and coaching, more out into real world practice. So, okay, Daniel, I see you've got your hand up. Please come on.
There are training programs that include MI in their training. As of 2021, there were 8 programs of the then 56 that include MI as part of their training, either as a full course or as lecture components. And there are a couple of articles that have been written on genetic counseling and MI. I put one in the chat, one of the first articles by Erin Ash, that refers to our reciprocal engagement model, which is the primary model of genetic counseling. So there are some of us that are trying to get more genetic counselors exposed to and to use and practice some of the skills to be MI compliant to the best of our abilities.
Thank you, Dan. I actually took down that reference you put in there.
Yay!
I don't know, maybe we need at the next, annual education meeting or something, we need to do some kind of...
They actually did have an MI that Erin Ash did back in maybe 2019 or 2018. And there have been a couple of articles. We actually published one here at Baylor on our training and training across the country that was published in 2021 in the Journal of Genetic Counseling.
Great. So we got to just keep getting the word out then, I guess. Just keep working at it. Thank you.
Thank you so much. I see we are at the top of the hour. I probably have another 10 or so questions for you, Amanda, but we'll catch up on the flip side for sure. But thank you again so much for your generosity and sharing your experience and your wisdom with us, and challenging each of us to do better and to be better in our healthcare conversations. So please all consider marking your calendars for upcoming MI Med sessions and future dates. Our next session will be at the start of the new year, so it will be in January. I just reposted the MI Med mailing list sign up, so please go ahead and sign up. You'll get information related to what the upcoming topics are, and as well the links to join. And again, and encourage you to share your ideas and suggestions for future topics that would be of help to you in your continued practice of motivational interviewing and coaching in healthcare. So thanks to each of you for joining the fun. Thanks so much, Amanda. Really took so many great pointers away. So we'll see you soon, and best wishes for an upcoming holiday season. All righty. Thanks all. Bye-bye.